Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto, Portugal. Today, I'm joined by Professor David Isenberg from the Lupus Academy Steering Committee, who will be providing expert insights from the key research and clinical data presented at the American College of Rheumatology annual meeting. This year was in Washington, D.C., last week, actually, November 2024. So, David, welcome.
Thank you very much indeed, Raquel. Lovely to be here.
And thank you so much for joining us, especially on this busy time, meetings and going across the world. Today, we're going to delve into highlights from this year's American College of Rheumatology meeting in Washington, D.C., ACR Convergence 2024. This year brought together top experts to share groundbreaking research and clinical insights into systemic lupus erythematosus and lupus nephritis. David, from the preview of the abstracts of ACR this year, it looks like exciting data was presented. First, CAR-T on SLE was presented a couple of years ago. It looked like it was going to be a more profound B-cell depleting therapy. But with these here presentations, we are more going to see that it works also by other different targets. And it's amazing the number of different CAR-T cell strategies that already have some data in lupus. What are your lights from those?
Well, I think you're right. A major talking point at the meeting was certainly the development about the CAR T cells. As you say, they began to emerge about a couple of years ago, and it might be worthwhile just reflecting on what they are aiming to do that conventional treatment does not do. Conventional B-cell depletion aims to get rid of the B-cells which are present in the circulation. And what this technology now is able to do by taking out the T-cells,
data was presented.
engineering them to recognize the CD19 markers on B-cells, is that these T-cells not only get into the circulation, they also get into the tissues, and that's very important. But unfortunately, the process using the autologous approach is very expensive because it requires obviously individualized approaches, which means at the moment patients are in hospital while this is going on, and they can be there for 10 to 14 days, and that's what adds to the cost. And I understand from talking to George Shett that the cost at the moment currently is in the order of 300 to 350,000 euros per patient, and that's a very expensive thing, and automatically restricts the number of countries where this could be done. But in addition, the number of centers where it can be done is restricted because you really need top-class oncology with top-class rheumatology and immunology to make it practical, to make it actually happen. But as you say, a number of other approaches are also being carried out, including allogeneic approaches and approaches which are going to utilize other kinds of cells. But that's very, very early days. And even with the patients who George Shett has studied, and he's now expanding his numbers of studies, the numbers of patients remain pretty small. He started off, as you know, with 8 patients with lupus. I think it was 3 with myositis, 4 with scleroderma. What it kind of dangles in front of us is the possibility of the C word, the cure word, which I'm very loath to use under normal circumstances. But what has happened in George's case is that after 12 weeks approximately, he claims he was able to stop all of the lupus treatments, including even hydroxychloroquine. And that in the patient who he's followed for the longest period of time, that patient has now been coming up to 4 years. So the notion that you could go 4 years post-treatment in a very active lupus patient is truly sensational. I mean, that's amazing stuff. Now, it may be that after 5 years, all of these patients will relapse and go back to square one. But what's fascinating is that what seems to come back is a normal immune system. Yeah. So in these patients, after the CAR T cell therapy, you don't see the autoantibodies which they had before the CAR T cell treatment. And that's amazing. I mean, it really is seriously amazing.
I think it's a little bit tricky what I'm going to ask you, but do you feel comfortable in taking out completely hydroxychloroquine after a treatment, even being CAR T cell particular?
Okay, so clearly I've been brought up in a world in which hydroxychloroquine therapy tends to be continued even in patients who've gone into remission. So for me, it's definitely, as you say, or as your question implies, a rather strange feeling. But equally, we are clearly entering a new era in the treatment, not just, of course, of lupus. And we're very fortunate in my own department, because in my own hospital, where we have a unit which has expertise, very profound expertise in oncology. And my colleagues have been using this form of treatment for approximately 8 years. So they come with great experience. And they've been very reassuring to me yesterday. They think it will be possible to get rid of everything. Now, whether that will prove to be the best strategy, we're not going to know for some time. But what is encouraging is that other groups around the world are now beginning to report early phase data. And one late breaking abstract, for example, was telling us all about some patients on the West Coast of America, 22 patients who are being treated in this way, with results which obviously don't have the longevity of the Gaudet patients. But 22 patients followed in several cases for up to a year. After 6 months, it begins to look as if the George data is going to be repeatable, and that was always the number one thing. Could somebody else repeat that? And the evidence from this group on the West Coast looks very encouraging.
Perfect. Let's see what's going to happen. Let's hope it's going to be like that.
Indeed.
And talking about new potential drugs, there was one molecule that was, I think, the absolute first presentation of its use in potential use in lupus. That was VENT-03, that it looks like it's a CGAS inhibitor. And there was abstracts that potentially it can be used in lupus. And another one that already mentioned before, a phase 1 and 2 trial, zetomipzomib, that is a selective immunoproteasome inhibitor, also showed improvement in lupus nephritis disease and SLE. Being early days, what are your expectations of these drugs?
Okay, so I think it's important really to link this to what we were just talking about. It seems to me highly unlikely that currently, at least with the current state of knowledge, that the majority of lupus patients are not going to be treated with CAR T-cell therapy. And therefore, we look to do things which are better than what we have available at the moment. So obviously anything which is potentially new is potentially very interesting. Now, the second of those drugs that you mentioned, as you I also had a problem with, it's the pronunciation of the drugs, which gets to be the hardest thing, really. And Zeto, hang on, I'll have to run at this. I think zetomipzomib is a selective immunoproteasome inhibitor. They've been doing a thing called the MISSION study. It's a study which is rather short-lived at the moment. The numbers of patients who they could evaluate, at least according to the work that they showed, was maybe about 10 patients. So we're looking at rather small numbers of patients at the moment. There's no reason, since they looked at patients who were very active, and they claimed that there were successes in terms of good improvements, both clinically and serologically, that this couldn't be an additional piece of armamentarium that we could use to treat patients with lupus. The VENT-03 that you mentioned, well, this is a very different molecule, as you mentioned. It relates to the blocking of CGAS, an innate immune sensor of nucleic acids, who, when aberrantly activated, leads to autoinflammation. And this leads to, or CGAS, under all circumstances, will activate a very important molecule called STING and other pro-inflammatory cytokines, and what has been demonstrated already is that genetic mutations in CGAS and STING leads to this infamous Atcardi-Goutier syndrome and a kind of chilblain form of lupus. So this looks very interesting if it's correct. But again, very, very early days. We're talking about phase 1 studies. So I think all you can say is so far, interesting theoretical approach, but really whether it's going to work in phase 2 or phase 3, we're not going to know for some time. But interesting approaches. But of course, there are other approaches which are much further down the lines, as you know.
Yes, and let's talk about some of them. There was some data also presented on phase 2 trials, mainly post-hoc data from previous trials that we knew some use of in lupus. The first one I would just mention is deucravacitinib. that is already clinically being used in psoriasis and in some countries also in psoriatic arthritis. And there we know there was a clinical trial in lupus, and these presentations were more on the analysis of, namely, efficacy by baseline demographics and disease characteristics, the results of the kinetics of response on mucocutaneous and musculoskeletal responses, and even in the subgroup of SSA positive antibody patients. And the other one that also was a phase 2 trial that we already heard about it, ianalumab, the long-term safety was presented in active lupus, and some new data on how long the B-cell depletion is. Do you have any comments on this data?
Okay, so the deucravacitinib phase 2 was published, I think, in the New England Journal of Medicine. It's an oral TYK2 inhibitor. It blocks the TYK2-mediated signaling of type 1 interferons, and that's gone through phase 2, as I've said. And certainly the SRI-4 data, which they presented up to 48 weeks, looks very, very encouraging. But there's a big phase 3 trial going on, and obviously, as you know, the FDA demands 2 phase 3 trials before they will think about improvement. So we need to see that phase 3 trial data. So again, all you can say is currently it all looks very encouraging, but still relatively early days. But so far, so good. The ianalumab, and the hardest part again is the pronunciation. This has been shown in a 68-week study to be safe and seemingly to be effective. It leads to quite a profound B-cell depletion, so that's very good. And you see reductions in both B cells and in some neutrophils. The SRI-4 seems to be sustained for quite a significant number of weeks, so that looks very good. And they've got a large phase 3 trials which are going on at the moment. So I'm pretty hopeful about this one, actually. This one looks encouraging so far. But again, we need to see that phase 3 trial data. And as you've implied, Raquel, we're sort of dangling a number of very exciting possibilities here. Not only have we got the CAR T-cell approach, but also for patients with whom it's not going to be possible to give it, almost certainly for reasons of expense as much as anything else. We've got the more classic rituximab, which is now widely used around the world. We've got the fully humanized version of obinutuzumab, which perhaps we'll come to. Although intriguingly, the company who did the phase 3 trial, which was reported as being successful, did not show that data. I thought they would show that data as a late breaker at the conference, but they didn't show it. So all we've got is the press announcement there. But again, the phase 2 we know was very successful, the Nobility trial. So that looked very good. It was a shame that they didn't show that data, but I'm told that they're preparing it for publication at the moment, which should be very exciting. And I think that given the fact that the real problem that we've got with rituximab is that 20% of it is mouse protein, so that unfortunately about a fifth of patients with lupus who are given this drug will eventually develop an allergic response to it and or a low level of IgG. So the fully humanized anti-CD20, the obinutuzumab, doesn't have those problems of being 20% mouse protein, so we should see far fewer problems with it. So the encouraging news is that the press claim says that it worked. We just haven't seen the data. We live in hope.
And let's move to a more near as trials, the phase 3 trials. And actually, this is a big news. So we have another possible kid on the block. So the phase 3, one of the phase 3 trials of dapiralizumab pegol had met its primary endpoints. So David, you are one of the authors of the trial, and what can we learn from this drug, and what else is needed? You also mentioned that phase 3, what else is needed to approve it?
Okay, so here is an absolutely amazing story, which goes back 25 years. I and Monica Mashter, Caroline Gordon, and about 60 other investigators were taken in about 1998 to a very, very splendid hotel in Vienna. And for 2.5 days, the company involved fired us at us a lot of information about the importance of blocking the CD40 ligand, which is very important in a whole variety of immunologic responses. And they said they've got this great drug, and that we went through in great detail. If the patient comes in on a Wednesday morning, it's the red tube. It's the Thursday morning, it's the green tube. And for 2 days, they really hammered us with extolling us the virtues of this drug. On the third morning, a most remarkable thing happened. I've never seen anything like this in my entire career, actually. So the guy who was leading the trial for Biogen was a lovely guy called Akshay Vaishnaw, who was originally trained in the UK, but had gone over to the pharma side a little while before them. And he came into this meeting, and there were, I say, about 60 investigators, maybe a dozen people working for the company. And he got onto the podium and he said, "Ladies and gentlemen, I'm afraid the news is not so good. We discovered just last night that a patient who was given this drug, we'll call it the early version of dapirolizumab, was given to a patient in Brussels. I'm sorry to tell you, this patient has had a stroke. In addition, I've become aware overnight of this patient in another part of the world, I think it was Rome, but it was a long time ago, has had a heart attack. So we've decided to cancel the trial. Oh, and by the way, unfortunately, my wife in Boston has an eye problem and I have to leave now." And he walked out. He just walked out. It was as if the waters parted before him. And he walked out, leaving behind him 60 very perplexed investigators and even more perplexed members of his own staff, who clearly knew very little information about, had no more information to impart than he just told us. So we were just left there. It was the most bizarre feeling. And we sort of walked outside and we thought, well, at least this means we've got half a day off. We'll go and have a look at Vienna, which was very nice. But it was a very strange feeling. And we all assumed that something had gone horribly wrong and that this would be the end of this molecule. But interestingly, people in the company said, well, actually, we still believe that the concept of blocking CD40 is important. So maybe we could try to find out where the problem actually lies. And it turned out that the problem lay in the FC region of this particular antibody, which has the capacity to aggregate platelets in a very unfortunate way. And then they said to themselves, well, what if we cut off the FC region, replace it with an inert molecule like polyethylene glycol? Surely the active molecule will still do good things. And that's actually is what dapirolizumab is. It's the FAB portion of an antibody which blocks the CD40 ligand, but it's linked to an inert FC. They don't even call it an FC region anymore, to an inert molecule, which is the PEG. And they've used this now in a phase 2 trial with great success, and a phase 3 trial with great success. And the guy who led this trial for the company is a guy called Christian Staub, and he's been very, very obsessive actually in his approach to this. And he was absolutely determined to make certain that the best centers that he could find would take part in the trial. Within those centers, the best people he could find would actually see the patients. He made sure they'd all have very good training. Christian Stack, by the way, sorry, not Stack, Christian Stack. And he was very, very obsessional in making sure that the best kind of assessments were being made for these patients. And I had quite a lot to do with the assessments as a kind of an arbiter where there were differences of opinion. So I really felt right along that if the approach was as correct as the company believed, he certainly was a very good guy to be leading it. And so it was a great pleasure to announce some weeks ago that the trial had met its endpoints using both the BitClass system, but it also met its endpoints with using SRI4. It met its endpoints in steroid reduction. The gap between the patients treated with the biologic drug and the placebo was in the region of 15 to 20%, which is very encouraging. And the data were presented as a late-breaking abstract on the last morning. And it really was one of the best presentations, I thought, because we here have got an approach which is logical. It makes sense. The company has spent, as I say, best part of 25 years getting this right. And finally, it looks like they have got it right. But as I've said, in order to convince the FDA, one phase 2 trial is not enough. You have to do 2 clinical trials of phase 3. So they're now planning a second phase 2 trial. These, by the way, are in non-renal lupus patients. So eventually they will have to go to renal patients. But they're going to a great deal of time and trouble to make sure that there's a good ethnic mix amongst the patients that they're testing. So I think it's going to be very, very interesting. And I think every reason to believe that the care that went into the first phase 3 will go into the second phase 3. And shortly, as in about 3 years' time, we should have a second phase 3, at which point it really ought to go into clinics and ought to be successful, because it does seem to be quite good across the board, but we don't yet know about renal disease. That's going to come later.
Perfect, good. Let's move to new data on approved drugs. And there was some abstracts presented of its use in SLE. And one of them, it's not a new drug that is available to use, are 3 old drugs that are used in lupus for long. So there was an abstract of an open label phase 3 trial comparing the remission rate of lupus nephritis by cyclophosphamide, MMF, or tacrolimus. And what do you think about the news of these results? Do you think we should continue doing these kinds of trials on old drugs? What are your comments on this?
Okay, so first of all, a little perspective on the use of cyclophosphamide. So cyclophosphamide got a bad press many years ago because the regime that was introduced by the NIH was overkill, really. They were using or recommended a gram every month for about a year, or even, I think every 6. Anyway, it was a total of 15 grams of cyclophosphamide. And what the European Lupus Consortium did was to show that you could use a fraction of that, 500 milligrams times 6, every 2 weeks, so 3 grams. So they compared the 3 grams under the new regime of the Euro Lupus criteria guys in Euro Lupus in Europe, compared to the original NIH regime, which is 14 to 15 grams of cyclophosphamide. And they showed, this was published years ago, that this treatment was as good and much safer, because clearly cyclophosphamide is a very powerful immunosuppressive drug, and there were problems with loss of periods, there were problems with infections, and by using the much lower dose, you could get the effect, but you just didn't see the side effects. So that was very good. So I think certainly, and obviously there are many countries where the biologic drugs are not so easily available. The notion that you could use reduced dose cyclophosphamide was a big step forward. And what this trial has shown, if you're comparing tacrolimus, which is an interesting, more specific approach for lupus nephritis, with mycophenolate and cyclophosphamide, you're getting results which are actually comparable. So I think that was a very interesting piece of work. And obviously it would be very valuable in countries and societies where the fancier, more expensive drugs are not so widely available. So I thought a very important study to show at the conference, and very, very interesting data.
Thank you for that. And then moving to more newer drugs, but already available. And there was quite a few abstracts on the real-world data of anifrolumab, and even post-hoc analysis of the trials, the TULIP trials, on remission mainly. What are your highlights on this data?
Okay, so there have been at least 2 studies reported out of Spain using anifrolumab. Now, anifrolumab, as you remember, in the TULIP trials, 2 phase 3 trials, some rather odd things happened in that they're non-renal lupus trials, and in the first trial, they used the SRI-4 as the primary endpoint and the BICLA as the secondary endpoint. And slightly bizarrely, the study did not meet the SRI-4 endpoint, but did meet BICLA. So they very carefully switched for the second trial, so the BICLA was the primary endpoint and SRI-4 was the secondary one, and BICLA was again met. So they could say to the FDA, look, we've got 2 successful trials using BICLA, albeit that only one was successful using SRI-4, and that was sufficient to persuade the American regulatory authorities to allow the production or to allow the sale and approval of anifrolumab. Now from Spain comes 2 studies, one 113 patients, one 105 patients, looking really at very useful information over longer periods of time, confirming that it's been effective. That is an effective drug. It's safe. The SLEDAI system, which they used, SRI, the SLEDAI was using the SLEDAI-2K, using the SRI-4. That seems to have been reached in these real life studies. It's also been given to refractory patients using patients who have got severe mucocutaneous and joint disease. Again, significant improvement. Good safety. These trials met the LLDAS and DORIS criteria for remission at about 3 months in the 105 patient study. So this does seem that in real life this drug is effective, that it does work, and that in those countries which can afford it, and UK sadly is not one of them because it has not been taken NICE yet, so we can't use it in the UK. But for those countries who are using anifrolumab, there's now very, very good real life data. This drug is effective and that it does work. We await really the complete data set in the renal lupus trials, which is what we need to see. That will come, I'm sure. But certainly for non-renal lupus, I think clearly there's going to be a place for this drug. And the work that Ed Vitale published some years ago at EULAR, for example, showed that it's particularly effective for patients with hard to treat dermatological disease. So really quite exciting stuff.
And there was also some abstracts from belimumab use, both real-world and retrospective studies. And there was one in particular that kept my view, a retrospective study on the early use of both hydroxychloroquine and belimumab, that are the risks and protective effects, but also larger integrative analysis on the trials of lowering disease flares versus placebo and early and sustained resolution of thrombocytopenia and nephritis. So belimumab is on the market for longer.
Yep.
And what do you think that we can expect more from this drug?
So here is a drug which was approved back in 2011. So it's been around for 13 years already. And I think most people's experience of it is twofold. First of all, it's very safe. So I think that's important to highlight. Secondly, it's rather slow in its onset. So I think when you choose to give a patient belimumab, you have to say to them, you have to warn them, this is not going to work like steroids. This is not going to work just like that. It's going to be 3 to 4 months before you really begin to feel the benefit. And my experience, for what it's worth, and we'll compare it to the data coming out of these other open label studies, is that it's pretty good in about a third of the patients. It's effective to some extent in about a third, and it doesn't work in about a third. And I think what's interesting now is that people are beginning to say, well, maybe we could use this preparation early in the course of lupus. Why wait till the patients have been on, shed loads of steroids and cartloads of other toxic immunosuppressive drugs like cyclophosphamide, even mycophenolate? Why not see if Benlysta, which seems to be a slightly gentler drug, if I could put it like that, maybe that could be very helpful. And such data as was presented at the conference would support that, I think. And I think combined with hydroxychloroquine, you're going to get a combination which I think will be slow in its onset, because that hasn't changed, I don't think. Will be safe, because I think that's very important, but will be, for a significant number of patients, perhaps as many as 2/3 of the patients, will give you benefit. But again, this is mainly focusing on patients with non-renal disease. It has been shown to be effective in a renal trial, though I think my colleagues on the nephrology side are still not as convinced that it's as effective as a B-cell depleting agent. But there is data to say that in a clinical trial that's effective. So I think it's certainly a drug which is going to be more widely used, and certainly when it comes off license, which will be in a few years' time, its price will go down even more, and it will be more widely available, more widely used.
And let's move a little bit to the patients' reported outcomes. Several abstracts on patients' reported outcomes, and there was actually 2 that I would highlight, but do feel free to mention others. One of them was the use of Lupus Impact Tracker and Lupus Pro on the Aurora trial analysis, and there were 3 items of the lupus symptoms that correlated with SLEDAI. That is not quite easy to correlate patients' reported outcomes with physicians' scores of activity. And the Lupin questionnaire was validated also and presented, and it showed a weak correlation with SLEDAI, but even also a correlation. So what do you think are the role of these questionnaires are playing on the patient's care?
Okay, so when I teach the students and colleagues about how patients with lupus are assessed, I try to emphasize that there are 3 elements to this. There's activity, which implies something which is potentially correctable. There is damage, which implies that it is present, but it's not correctable. And it's important, for example, to highlight in the context of, let's say a patient presents with hip pain. Now, the hip pain could be due to active inflammation, which might respond, for example, to a local steroid injection. It might be due to avascular necrosis, which might have been caused by steroids. So the last thing that you want to do is to give a patient any more steroids. And the third element, and this is where these self-administered questionnaires come in, is the patient's view of the disease, which is often radically different from that of the physician. And I learned this the hard way myself years ago. One of the very first things I ever did when I got to the lupus clinic was to ask 100 successively attending patients, what is the #1 feature of lupus that troubles you the most? And I assumed it would be fear of kidney failure, fear of death. And they all said, no, it's fatigue. The problem is I'm too tired to get up and take the kids to school in the morning. I'm too tired to go and collect them from school in the morning. So it's very important to recognize that for the patients, what worries the physician is not the same as what worries the patient. So they're really quite different things. And for years, we have struggled to try to capture that in a whole variety of ways. And perhaps the best known one is the SF-36, which actually it has a certain Goldilocks quality to it in the sense that it started off as the SF-200. So that's how it got kicked off with. And it was also incidentally based upon an assessment of 10,000 healthy people in the Nottingham region of England. Who knew there were so many fundamentally healthy people in the Nottingham region of England? We now know that. So they decided that SF-200 was too many. So then they cut it down to SF-12, and they decided that was too few. So then they came up with SF-36, which seems to be about right. But the problem, of course, is the SF-36 is a generic thing. It's not specifically focused on lupus. And so in Blackburn, Lancashire, and as Raquel perhaps will know, perhaps but some of our listeners, Blackburn, Lancashire is very famous for very few things, but one of which is a Beatles song. 10,000 Holes in Blackburn, Lancashire was what John Lennon sang about it. But it's now very famous for the lupus quoll, which was introduced by colleagues in Blackburn in Lancashire. In particular, Dr. Lee Tay was the person who developed that. But that itself is a little bit complicated. So others have looked for slightly easier ones. And the Lupin self-administered questionnaire, as you say, focuses on things like pain and fatigue and lupus. It looks at brain fog, which is very important. It incorporates some elements of physical activity from other lupus activities, other lupus self-awareness questionnaires, and it does seem to be quite a useful way to go. So that's all well and good. How it will stack up against the lupus quoll, which I think has stood the test of time, I'm not quite sure. But it was used in the studies that you mentioned, and Dr. Jolly from the States has been particularly helpful in trying to present this work and the lupus tracker that you mentioned. So I think we are certainly entering an era where people are looking very hard to find something which is perhaps a little faster, a little quicker, which patients could undertake perhaps while they're waiting to see their physicians in the clinic. So I think these tools will become more widely used in lupus clinical trials and will certainly work their way into clinical practice. I think that's probably true.
Finally, let's just go through the new updated ACR guideline for the diagnosis and treatment of lupus nephritis. It was presented and discussed. And do you think there's anything new on the approach? What are your thoughts on these updated guidelines?
Okay, so these guidelines seem to get updated every 3 to 4 years. And I think certainly with the development of the CAR T-cell therapies that we've been talking about, this is probably going to be needed again in another 3 or 4 years' time. The new guidelines for the first time give advice about the treatment of children and adolescents, which has not been done before. So I think that was very important. They seem to sort of make a very important distinction about induction therapy, about treatment and monitoring, and they have some new things to say. They're talking very much now about the importance of triple therapy, which includes in the main steroids with classic immunosuppressive drugs such as mycophenolate or cyclophosphamide. That seems to be very important. Then added on additional drugs like calcineurin inhibitors, which I think also very important, especially for class 5 drugs. Monitoring is emphasized here and is very important. And they emphasize that we shouldn't forget that it's claimed that in many studies, 30% mortality at 10 years for patients with lupus nephritis remains very worrying. They emphasize that trials have continued to report 10 to 22% end-stage renal disease in patients, although perhaps not as much emphasis as I would have liked on the importance of making sure the patient is actually taking the drugs. Because for me, the number one cause of end-stage renal failure in lupus patients is failure to take the medication. The number 2 reason is failure to take the medication. The number 3 reason is failure to take the medication. And number 4, severity of the disease. So I think that's so which you really have to get across to physicians and, of course, as to patients. And, of course, this is particularly true in adolescents, where it is notorious adolescents don't take their medications, unfortunately. So certainly the adolescents that I've looked after over the years, these problems have sometimes been enhanced by challenging parents who have very bizarre beliefs in some cases. I remember some particular parents who have believed that their children's or the child's lupus nephritis is due to a fungal infection. And I've been repeatedly begged, isn't it about time we started out my daughter, my son, on the antifungal treatment? And you have to, no, it's got nothing to do with a fungal treatment. It's the serious condition. So I think that they will need a little bit of time to go through it in a little more detail. But as I say, I emphasize their advice is now being offered on the treatment for children and adolescents. And this sort of the triple therapy approach is being strongly supported, recognizing that drugs like Benlysta will, I think, have a part to play. I think that's very important too. A little bit of emphasis on the use of voclosporin, and that's very important too. And also when things fail, the B cell depletion is going to still remains a good way to go. But for me, I think the timing is a little bit unfortunate in that we're going to know in probably a couple of years' time whether or not CAR T cell therapy is going to be added into the guideline treatments. So that's going to be interesting. And as we've discussed this afternoon, a whole host of other drugs coming through the system, two of which I think are highly likely to be approved by the FDA, and that's obinutuzumab and, if the second phase 3 works, the anti-CD40 ligand approach with dapirolizumab. But truly, Raquel, I think genuinely very exciting times in the treatments of lupus. And although I know this is largely our end topic, I would throw in a couple of things just to mention en passant. One was a very good study on osteoporosis in lupus, the work of colleagues done in Baltimore by Michelle Petrie, looking at 3,000 patients and reminding us of the importance of getting those oral steroids down as low as you can, because there's no doubt from her study that the higher the dose of steroids, the more likely you're going to get to osteoporosis. And also a nice little study for a very big study done from a community network looking at the frequency and severity of thrombocytopenia in lupus. This was a study of thousands of patients. Their report was about just under 10% of lupus patients get thrombocytopenia. I actually asked a question, this was presented at one of the sessions, whether or not, how often the very severe forms of thrombocytopenia, platelet counts less than 30, they reckoned about 0.5% of the patients overall. And I asked about how often that led to severe bleeding, because I've been amazed with some of our patients where the platelet counts have gone down to less than 20, and they don't bleed. A few bruises, but nothing serious. And they didn't have that information because, in our experience, although you get low platelets, it appears that they may not be large in number, but they're high in quality. They seem to keep the patients not from bleeding too badly.
You might have a lower health related quality of life, but you have a good quality of platelets when they are low.
Absolutely. Absolutely.
David, thank you so much. It was a big congress, very, very hardworking for you also. And so thank you so much for joining me today and sharing your insights. To you, our listeners, we hope these discussions from ACR 2024 have helped you gain more of an understanding of lupus. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world.